Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Ovulation disorders, that means now again we are talking about what are the different reasons for ovulation disorders. Now come on, tell me. That is also split into 3. Yes, tell me. Yes, guys. Is there a... Yeah, I think I asked you. What's your name, please? Could you please let me know your name? Oh, Sujata. Sorry, Sujata. I'll just change your name so that I don't confuse you. Is there a problem still? All right, no problem. Then it's fine. Yeah, your name was not with me. It was giving some new student, and this is what happened in the last class also. Somebody was, I don't know how the person was added, but they were trying to approach my students with my name. So these people are very smart, you know. I don't know how they get different ways of contacting my students, and then they start taking money from them, and there are certain people who fall for these scams as well. Yeah. So the different causes for ovulation disorders, let me know that. That's the last one. Remember WHO causes? WHO 1, 2, 3. Anyone remembers that? This is what I'm trying to remember. This is what I'm trying to tell you right now, guys. This table will make you remember. WHO class 1, 2, 3. Yes. Hypogonadotropic hypogonadism, normogonadotropic normogonadism, and hypergonadotropic hypogonadism. Yes. Hold your head like this, all of you. This is the question that I asked you. You should know this by now, right? And I'm sure you all know it. Just probably the way I ask question, probably you could not understand what I mean by that. So ovulation, the problems with ovulation can be 3 kinds. And which is the reason why WHO has classified these 3 problems into 3 categories. One is in which there's something wrong with the hypothalamus or pituitary. The second one is in which there is no problem anywhere. Okay, still the ovulation is not taking place. Probably something to do with the ovaries, I guess. PCOS or thyroid dysfunction. Ovulation is there, but very erratic. Then is hypergonadotropic hypogonadism. That means pituitary, hypothalamus are working fine, but the ovary is just not working. So they are trying to stimulate it, but it's not working. Okay. So the third category is your premature ovarian failure, okay, or chemotherapy, radiotherapy, or streak gonads, because of which they are not working at all, and this is going in overdrive. So you have FSH, which is very high, E2 is very low, and this is hypergonadotropic hypogonadism. The normal one is actually PCOS or thyroid problems, and the hypogonadotropic hypogonadism, something, all the entire axis is gone. You have functional hypothalamic amenorrhea, anorexia. You just talked about it, isn't it? So what do we do? What do we do with this patient? So first of all, you always, when you start the diagnostic algorithm, you always start with history, examination, ask how our cycles are, there's got any problem with the cycles, and whether she's had any child before, and whether it is documented, evidence of ovulation at any point in time. Then you'd like to go for investigations. You'd like to at least do FSH and AMH, because FSH will tell you whether she's having premature ovarian failure. AMH is going to tell you whether she has ovarian reserve or not. Okay. Mid-luteal progesterone, extremely important and favorite of RCOG. Around day 21, you'd like to do mid-serum progesterone, and it should be more than 30 nanomoles per liter. And that tells you whether the patient is ovulating or not. If the patient is having erratic cycles, maybe 35 days, 37 days, then you have to keep doing this ovulation test, that is serum progesterone, every 7 days from 21 days onward, day 21 onward. So that means day 21 you'll do a test, day 28 you'll do a test, until she gets a cycle. Every 7 days you'll do a test to find out what is the level of serum progesterone. At any point in time, if it increases more than 30, she has ovulated. Okay. Then you of course do prolactin, you of course do TSH. Mostly in all cases of infertility, male, female, you at least do a baseline TSH and prolactin, though they do not encourage in RCOG. when I'll take up your classes for practicals, I will discourage you a little to speak very frankly of prolactin and TSH. But here, in ovulated causes, there's one more category called as hyperprolactinemia that will cause ovulation. So we will keep it there as it is. And of course, you like to do a TVS because you like to see at least an altered follicle count. And not only that, you might even require a follicle monitoring, which is the most obvious test for ovulation. So once you do get to know, then I'll tell you how do we manage these patients. But otherwise also, BMI should be strictly between 20 to 26. Here they've said 19 to 30. It's more between 20 to 26 BMI, right? Even a weight loss of 5% can restore ovulation in the PCOS patient. Should not be vigorous exercise, but she should exercise at least 5 days a week. Folic acid supplementation can be given if she's an alcoholic, smoker, drug abuser, whatever. Please stop all these things. Excessive caffeine intake, not good. Now, each, problem one by one. For example, WHO category 1. She is having hypogonadotropic hypogonadism. Now, just quickly tell me, pre-testicular causes, how did we manage the patient? We gave a pulsatile GnRH, or we gave a pump, or we gave the gonadotropins directly. Yes, the same thing we do here. We give a GnRH pulsatile release pump, or we give regular gonadotropins twice a week for 3 to 6 months, and we continue it for 1.5 years for good results. So here you will get a good result once you've started giving it. Endogenously, they don't have gonadotropins. So exogenously, you are giving them gonadotropins, either through pulsatile GnRH release or through gonadotropins directly to them. So once you do have the gonadotropins, suddenly the ovaries will get stimulated and they will start producing the eggs. Okay, this is how you will manage WHO category 1. WHO category 2, PCOS, I'll just zip my mouth because all of you already know. Their favorite drug for ovulation induction in PCOS females is letrozole and not clone. Okay? So it's 2.5 letrozole, 2.5 milligram letrozole, OD, day 3 to day 7 or day 2 to day 6, whatever. And you keep increasing it from 5 to 7.5 depending upon when and how she having the ovulation. And usually ovulation rate is 60 to 80%. Not only that, endometrium is also benefited with this kind of, with this drug. And of course, you do the follicle monitoring. You might give an HCG trigger and then you try the, IUI cycles or whatever you want. Hyperprolactinemia, you have to give a dopamine agonist. And then you, for 3 to 6 months, and then you call her back again and check the prolactin levels and you stop. What do you do in premature ovarian insufficiency or premature ovarian failure? You go for oocyte donation, guys. There is no first or second line. Hormone replacement is only for health. It's not for fertility. For fertility, you have to go for oocyte donation or adoption. That's the answer. This is not second line. It's actually the line. Here, this is the first line. I agree with this. Clone, letrozole is preferred. Here, you can go for any of these. I don't mind. But here, this is the first one. Now, this is how I've tried to, what do I say, satisfy those students who wanted my ovulation induction as well. There's a complete lecture I have for everybody who's got my theory notes. The lecture on ovulation induction regimes, and part of it is over here. Like for what you start from day 2 to day 3. You give a baseline scan, you do labs, and you start the drug. And day 8 to 10, you do the first ultrasound monitoring of the follicle. And you keep doing it until a dominant follicle around 18 millimeters is seen, and then you give an HCG trigger. And then you ask them to have a timed intercourse 24 to 36 hours post the trigger. And if you require, you might give a luteal support. Okay. Now, if the age is more than 36, you do not go on to further. You have to move after 3 to 4 cycles. Maybe she requires IVF now. Correct, guys? Now, okay, with this, for this time, I'm just removing it. I'll tell you when and how to treat this. Now, IUI, can quickly somebody tell me the reasons for IUI? Would you like to do in for, would you like to go in for IUI for unexplained infertility? Yes or no? First of all, first question, would you like IUI for unexplained infertility? Yes or no? Okay, Sujata says yes. Yeah, I'll give you the answer. Now, first of all, tell me the indications for IUI. I have very specific indications for IUI. Yes, very good, Champe. Male factor infertility, that means if you're having retrograde ejaculation, premature ejaculation, erectile dysfunction, and at the same time, female partner is having vaginismus, she's not able to have any intercourse. So then in that case, you'd like to go for IUI. What are the other reasons? IUI. Cervical cavity. Yes, cervical factor. Agreed with Swati. Agreed with Namrita. Absolutely right. Cervical factor is another choice. Another thing. Any other thing? All this is covered. When we say antibodies, we usually want to talk about the cervical factor. Anything else? I have very characteristic answers still left. Very important answers are still left. In which patients would you like to do? Hypospadiasis. Okay, I mean, they are basically causes because of which the patient is not able to achieve, coitus for whatever reasons, right? Okay, fine. That's over. Anything else? Anshu, welcome back. I was so unhappy when you left. I was like, my God, what happened to Anshu? Good, Anshu, that you're back, and it's very nice to see these glitches will happen, beta. We are living in a world of AI. We are intruded by AI now. So these things will keep happening. The thing is that you have to be very, very cautious. Okay. Unexplained infertility. Okay, that's a little controversial. Anything else? Anything else, guys? Okay, what about same gender couples? Don't you think they will have IUI from somewhere? The donors firms or something, right? Okay. PCOS we usually don't go for IUI. They are happy with ovulation induction most of the time. Okay, now you'll be very surprised when I'll share the indications, and then you'll say, oh God, why didn't I not say that? So they do say that unexplained infertility is one of the indications, but mild male factor infertility, like the count is more than 5, but not so good. Like I told you, the cutoff is 16 and 39, right? What if it's 20 per ejaculate? It's not very bad. It's not very good. These patients will benefit with IUI. Mild endometriosis stage 1 and 2 will help. Okay. And ejaculation, sexual dysfunction, which we all said elaborately. Need for donor sperms, single women, same-sex couples. Cervical factor, everybody said. HIV positive couples. You don't want to have intercourse, but you need the sperms. Correct? Later on, they can have sex with condoms, but right now, when you require the sperms, you'll take it separately, and then you'll put the sperms inside as IUI. But there are certain prerequisites. Okay, bilateral tube pregnancy. You cannot go for IUI procedure without checking the tubes. Ovarian reserve should be reasonable. Female age should be less than 40, preferably, because even after the moment she touches 39 or 40, you straight away send her to IVF. If she's not conceiving up till now, whatever might be the reason, just send her for IVF direct. Less than 39 weeks, 39 years, maybe 36 to 39 years, you can still give her 6 months chance. Above that, just straight IVF. That's the rule now by RCOG. So they say the success rate is as good as 10 to 15% per cycle. They say if you do 3 cycles, the chances are around 50%. And if you do 6 cycles, then chances are about 75% good. That's what's said about IUI. So IUI is a better procedure, and that's the only thing you can offer to her before IVF. Correct? So yes, you do unexplained fertility, but not it's age dependent. For unexplained fertility, it's a good choice, but it's age dependent is what I'm trying to stress upon. If she's less than 35 years, you can try IUI. If she's more than 35 years but less than 39 years, give her 6 months. If she's more than 39 years, IVF, straight IVF. After 6 months, in 35 to 39 is IVF. No IUI. And what are the indications for IVF and ICSI, guys? Severe male factor. The less than 1 million, even less than 5 million, I'll say. Oh, wait, I'll just change it to less than 5 million. There's no 1 million category here, 5 million. Moderate or severe endometriosis. Yes, correct. Recurrent anovulation, unresponsive to medical management. If you want to do a pre-genetic analysis. Women more than 40 years or AMH less than 5 after individualized counseling. After 3 failed IUIs for unexplained infertility or mild male factor, please make sure that she goes in for IVF.